Hello, everyone. Thank you for tuning in to uh, this recording. This recording is going to cover some topics in OB/GYN, particularly pregnancy hypertension and hepatic presentation. In my experience, there's a little bit of overlap between them, and I thought that it would be good to go ahead and see if we can work through some of the differentials and highlight some of the thinking that you need to have whenever you're presented with cases that look similar to this. So let's get started. So here we have our first case. I'll give you a second to pause and see if you see what you highlight and find most important for it. So hopefully you saw things that were similar to what we have here. I also want to note in particular that I did not have in the pre-highlighted portion that there's no history of hypertension prior to the pregnancy. Okay. So again, the things that we're looking at in particular is that the elevated blood pressure is above 160 over 110, a thrombocytopenia with platelets less than 100,000, elevated liver enzymes, and then also elevated creatinine, right? And then we have this presentation associated with headaches and visual disturbances, right? As well as a proteinuria. So that should lead you in the direction of having a diagnosis, a clinical diagnosis, and lab confirmed diagnosis of preeclampsia with severe features. And so in this discussion, we'll talk about the difference between preeclampsia with severe features, and eclampsia, right? But let's take a look at some of the differentials that you might have in addition to preeclampsia with severe features. So I don't have them listed here. I don't have preeclampsia with severe features listed here, but these are some other four things that you might want to consider based on some of the presentations, right? So hypertension in general, maybe a chronic hypertension. We have some things that, note that why this isn't chronic hypertension. HELP syndrome, we have some presentations that might lead to that, but again, there's some key differences that would prevent that, as well as eclampsia and acute fatty liver pregnancy. Okay, so why wouldn't it be these items? So for the items that or reasons to exclude those four differentials, let's just note that for eclampsia, if the patient has all of these symptoms but no seizure, then they don't have eclampsia. So eclampsia is going to be that introduction to seizures during or with a patient that has had a prior preeclampsia diagnosis or is essentially presenting with a hypertensive episode while pregnant and then progresses to seizures. HELP syndrome. Um, they're missing the H portion of this in terms of hemolytic anemia. So we don't have any indications of a hemolytic anemia occurring in this particular patient. So it would be HELP syndrome. Chronic hypertension, as stated, as I highlighted additionally here, there's no history of hypertension prior to pregnancy. So we haven't had any hypertension problems, so it can't be chronic hypertension. And please note that your cutoff is going to be at 20 weeks. And then last but not least, please forgive me, for acute fatty liver pregnancy, we don't have any signs of hepatic failure or hypoglycemia. And also of note is that we don't, for typically associated with this, we're not going to pair it with um, hypertensive episodes, right? Unless there's some sort of overlap, which would include a hypoglycemia that really stand out if you have concerns or looking for a differential there, right? So what would we do in the management of this particular patient? Well, hopefully you selected A, right, to recognize that we would administer antihypertensive therapy in order to bring that blood pressure down, especially because we're in a crisis, and then initiate magnesium sulfate as a prophylaxis to prevent progression to eclampsia and plan for delivery because delivery is the only definitive cure to remedy preeclampsia and eclampsia. Okay. Let's clear this and move on to the next portion here. So we can go right into pregnancy hypertension pathologies. Okay, so as stated before, chronic hypertension is typically presenting before that 20-week gestation mark, right? If we wanted to add a diagnosis of chronic hypertension post partum, we're looking for that to occur after 12 weeks have passed since delivery, right? So I want you to think of 20 and 12 whenever we're discussing chronic hypertension in terms of gestation period and then also postpartum, okay? Of note, outside of the pre-existing hypertension portion of it, you're typically not going to associate it with proteinuria or severe features, right? Um, in the event that that starts to occur, particularly after 20 weeks, then we're going to say we have superimposed preeclampsia, but typically you're not going to see that as well, right? Because patients with chronic hypertension during pregnancy are at increased risk for preeclampsia, you might want to add a low dose aspirin, right, as a preventative a preventative task there, and then also going to make sure that you're optimizing blood pressure medications as much as possible during the pre-pregnancy period. Okay. Please note that just as we know, outside of OB/GYN and just in general medicine, that hypertension is designated as greater than 140 over 190. And so you're looking at to see that again before 2 weeks gestation, typically associated with two visits, at least 4 hours apart. Okay. Your first line medications are oral antihypertensives, so labetalol, nifedipine, methyl-dopa. Methyl-dopa is used a little bit less often in modern day, but it is still a technical answer, right? But we're going to lean towards labetalol and nifedipine in particular for a pregnant patient. You're going to closely monitor, or you're going to monitor for superimposed preeclampsia, right? And again, you might consider using a low-dose aspirin as a prophylaxis and preventative. In terms of third line, again, we just want to make sure that everyone is stable in terms of your patients as you move towards delivery. Okay. So let's talk about preeclampsia. So within the next couple of slides, I just want to make sure that we're noting a few different things. Well, number one, what are the hallmark features? Not just hallmark features, but what are the key differentials in terms of our diagnosis? So for preeclampsia, again, new onset hypertension after 20 weeks, and then it's associated with a mild proteinuria. I also want to note that there is no end organ dysfunction, no end organ dysfunction. Please allow that to be one of your key differentiators as you're looking between preeclampsia and eclampsia. Also, please note that you have to couple your hypertensive presentation with a proteinuria. So hypertension without proteinuria, we're not really moving into a preeclampsia diagnosis, right? But we are going to be on the lookout for it. And as I stated here in your diagnosis criteria, we are looking for a hypertension paired with proteinuria, hypertension paired with proteinuria. Please remember zero point 0.3. You're not always going to be able to monitor urine protein levels for a 24-hour period, so that ratio of zero point 0.3 of protein to creatinine can be very helpful. Okay, so again, preeclampsia, hypertension, and protein. Preeclampsia, hypertension, and protein. That's what we're thinking. That's where our concern is. Our first line treatment for preeclampsia, we want to manage. If we can manage and increase stability and make sure everyone is as healthy as possible up until full term and beyond 37 weeks, let's do that. So for preeclampsia, we're looking at 37 weeks as our goal, right? But if it persists, we need to deliver at 37 weeks. If we can persist beyond and keep everything stable, let's do it. But if not, we can deliver, and we should deliver at 37 weeks. If we enter into a crisis, though, right, because that crisis point is going to be above 160 over 110, we need to consider administering labetalol, hydralazine, and nifedipine, right? Quite possibly an IV in order to try to stabilize and reduce that blood pressure. Okay, so this is preeclampsia. Again, the focus is hypertension and protein. So when we decide to add the phrasing of severe features, we should probably consider some differentials or some additional presentations, including headache, visual changes, elevated LFTs, thrombocytopenia, creatinine above 1.1, and pulmonary edema, right? And so and these are all going to fall into the categories of evidence of end organ dysfunction. So evidence of end organ dysfunction, or the things that we just mentioned there. Okay, so that should pique your alarm, and those are the things that we saw in that first case. So what are the diagnostic tools in terms of numbers? Well, first and foremost, as we said before, and this was towards the end of preeclampsia or moving into a preeclamptic crisis, is when you have blood pressure elevated above 160 over 110. That thrombocytopenia, if you see platelets below 100,000 and you still have your other two considerations of blood pressure and proteinuria, then you have a severe feature, right? You only need one of these. And I mentioned that, I emphasize that because that's a subtle thing that you might see in labs with everything else looking relatively normal. Okay, so creatinine above 1.1 or double the baseline that was initiated, particularly at visit or a prior visit, or you're looking for liver enzymes that are typically 2x of the normal limit. So liver enzymes that are 2x of the normal limit. Okay, if you've been on the wards, you might remember asking the question to patients if they have a persistent right upper quadrant epigastric pain, as that's one of our signs and concerns for liver function, and then also pulmonary edema and new onset cerebral or visual symptoms, as was seen in our first case there. So, what's the treatment? So, hopefully, you're thinking that the treatment is going to include stopping things where they are and preventing a seizure, right? So, number one, we want to initiate magnesium sulfate procedure prophylaxis. So, yes, we should also think that we want to control hypertension, but dealing with a seizure can have significant impact for the health of both of your patients. So, as a result, we want to make sure we're initiating magnesium sulfate, and then at the same time, if not shortly thereafter, making sure we have IV antihypertensives, right? But this indication of preeclampsia with severe features, we need to move to magnesium. With severe features, we need to move to magnesium. Okay. As stated before, again, the antihypertensives provided at this point are going to be labetalol, hydralazine, and nifedipine. And then, of course, you want to keep things stabilized so that you can eventually deliver, because we know that that's the only definitive cure. So the only difference between preeclampsia and eclampsia, I'm sorry, preeclampsia with severe features and preeclampsia, as we previously stated, would be the week that we are concerned with. Previously, it was 37 weeks. Now it's going to be 34 weeks. Okay. So your differentiators, please recognize what are the symptoms that are designated as end organ dysfunction. Please remember which weeks are going to be most important whenever differentiating between preeclampsia and preeclampsia with severe features. So now we progress to eclampsia, and this is something that I stated earlier. So basically, we most likely have had a pre-eclamptic diagnosis or diagnosis of preeclampsia in some form, but then we've introduced a tonic-clonic seizure, right? So you might or might not have been able to take a proper history or a proper consideration for preeclampsia when the seizure presents. But please note that if you're having a hypertensive crisis paired with a seizure in a pregnant patient, then we are thinking eclampsia. Okay. So again, seizure with signs and symptoms of preeclampsia. Preeclampsia is just a hypertensive uh, consideration, right? So please make sure you're also excluding any other causes. If the patient has epilepsy, they might not that that doesn't necessarily mean the patient has eclampsia, right? So you're looking at the blood pressure as your differentiator there, right? Same thing in terms of infections, particularly septic infections. What would your blood pressure do during sepsis? Significantly decrease, right? And then structural brain lesions, which you might see in terms of a patient having a past history of some sort of significant trauma or what have you. Um, okay. And then in terms of treatment, under the same guise, we're still trying to make sure we can monitor and control and stabilize um, this seizure. So we're going to use magnesium sulfate. And then we're also going to make sure we stabilize the airway, try to control the blood pressure, as we mentioned with some of our medications, and then monitor the fetus. Okay. And then after we get as much stabilization as possible, we want to move towards delivery. So with eclampsia, we are less concerned about the gestational age. So we've gone from 37 weeks to 34 weeks to no concern for gestational age. We need to go ahead and deliver the child. Okay. For HELP syndrome, this is a kind of a spinoff or consideration similar to preeclampsia with severe features. You've just added the unique consideration that we've paired elevated liver enzymes, low platelets with hemolytic anemia, right? So in terms of presentation, right upper quadrant or epigastric pain paired with nausea, vomiting, right? That's going to be one of the things that we're looking for. And then, of course, an overlap with or preceding preeclamptic signs, right? So that nausea, vomiting, I believe this is the first time that we specifically mentioned nausea, vomiting. So we might want to go ahead and consider things like getting a blood test so that we can see, or getting a serum test so we can see what's going on in terms of red blood cells. So hemolysis, what might you see? Elevated LDH and peripheral smear with schistocytes. And even if you don't have this, if we have our elevated liver enzymes and decreased platelets, maybe we're seeing a reduce in red blood cells. Um, that's not explained by the hypervolemia associated with pregnancy, but we have significantly decreased red blood cells with these features, and you basically your preeclamptic setting. We're considering HELP syndrome, right? So what are we doing to manage that? So since we are still dealing with a preeclamptic situation, we need to stabilize, manage your blood pressure, and manage blood pressure and administer magnesium sulfate. Remember, we are still in a preeclamptic with severe feature crisis. So we want to consider adding magnesium sulfate. If we are beyond 34 weeks, we need to consider delivery. Not just consider it, but do it immediately. That's the plan, right? But if we're less than 34 weeks, then we would consider corticosteroids in order to protect fetal lung maturity. Okay, so again, HELP syndrome is an extension of preeclampsia with severe features. We've just added a hemolytic crisis to the situation. 34 weeks is your metric, and if we're less than 34 weeks, we're going to consider corticosteroids. Okay. Now, for pregnancy with hepatic pathologies, pregnancy hepatic pathologies, again, as you know, I've said elevated liver enzymes a couple of times. So it's part of the reasons why I want to make sure that we at least discuss this before we move on to some questions. So the first one was mentioned in the vignette in terms of acute fatty liver of pregnancy. For this one, it's typically occurring in the third trimester, right? And you're going to look at it in terms of having profound nausea, vomiting, right upper quadrant pain, and jaundice, right? And that might sound kind of similar to your HELP syndrome, but note I didn't make any comment in terms of hypertension. So if we're seeing this in the absence of hypertension, we're moving towards acute fatty liver of pregnancy. Okay. Now, because we're dealing with fatty liver, excuse me, acute fatty liver of pregnancy, some of the signs that we're looking at in terms of liver failure might include hypoglycemia, coagulopathy, and encephalopathy, right? So please be cognizant of bleeding issues. Please be cognizant of signs of hypoglycemia. Please be cognizant of encephalopathy. And if you see these three, and maybe the patient is losing consciousness or is not particularly responsive, and you're not able to capture some of this other information, but the patient is pregnant, I want you to seriously consider acute fatty liver pregnancy. Okay. So what are we looking at in terms of labs? Well, obviously, as mentioned before, hypoglycemia. That elevated ammonia is going to what's leading us towards encephalopathy. Our prolonged PT or INR is going to lead us to the coagulopathy. Elevated liver enzymes, as we said, this is a liver problem. And then a unique feature as well would be leukocytosis. So leukocytosis and hypoglycemia are two of my favorite things to look at in terms of trying to differentiate whenever you're looking at the labs for these particular types of presentations. Okay. Now, this could be confirmed with imaging or liver biopsy, but that's not something that you're going to see or answer all the time, right? I don't want you to have that as your benchmark for success there. This can be clinically and diagnosed in the lab confirmed before you move into your treatment options. So what will your treatment options be? We need to stabilize the mother, and we need to manage the glucose and the coagulopathy, right? We need to decrease the bleeding crisis, and we need to manage the glucose. Um, Furthermore, once we get some stabilization, we would probably want to move towards delivery regardless of gestational age, right? So there's only a couple of settings in which we said that we wanted to move towards delivery regardless of gestational age, right? One of them would be acute fatty liver of pregnancy, and the other one was eclampsia, right? So please make note of when we want to move towards delivery. That's going to be important in your decision making for your exams and on rounds. Okay. And then, of course, third line would be ICU, particularly if we've moved towards severe hepatic failure. Okay. So intrahepatic cholestasis of pregnancy, or ICP, right? So ICP is occurring and is presenting in a way where you have one of the hallmark features is going to be intense itchiness, right? Um, so intense itchiness, particularly of the palms and soles, and it's often worse at night, right? So, and for this feature, for this presentation as well, you might often see dark urine and pale stools and elevated bile acids, right? And this often occurs in the third trimester. All right. So how are we going to diagnose this, right? So we're going to diagnose this by seeing your elevated serum bile acids, elevated LFTs, and on your labs, you would note normal platelet counts and coagulation parameters, no hemolysis or severe hepatic features. So I want you to think of this as a situation where, versus your acute, or versus your acute fatty liver pregnancy, where you do have some significant changes in terms of coagulopathy. We don't necessarily have that for ICP, right? Um, so allow that to be in terms of your differentiators there. And notice how I also didn't say anything about hypertension. So you might have elevated LFTs, but if the blood pressure is normal and the patient is relatively stable, then aside from the itchiness, then we're probably thinking of ICP. So how is it treated? Right? So it's treated with ursodeoxycholic acid, or UDCA, in order to improve your bile flow, right? And that should reduce your bile acid levels as well. Okay. So what's your second line treatment? So your second line treatment is going to be um, mainly symptomatic. So antihistamines are topical agents in order to provide relief from the itchiness. So we're trying to increase bowel flow, reduce the symptomology of it, and then we can early delivery at 37 weeks, so just to make sure that we've tried to get as close to full term as possible, um, and move forward from there. Okay. And so HG, hyperemesis gravidarum. Always have issues pronouncing that. But for HG, you're typically going to present with a severe nausea, vomiting, and then the weight loss consideration. Please note whenever you're presented, a patient's weight at one point, and then the patient's weight is decreased by more than 5% of their pre-pregnancy weight, we are concerned for HG, right? So signs of dehydration, signs of ketosis, and this is often happening in your first trimester, right? Often happening in your first trimester. Um, and then with this, it might cause some mild transaminitis, right? And so you could prevent this by, I've seen it in the clinic all the time whenever they make recommendations for vitamin B6 supplementation, and then also starting with early antiemetics early on, especially if they have a history of HG, right? So what are we seeing in the labs? So ketones in the urine, hypokalemia, and hypochloremic metabolic alkalosis. Please be cognizant of this particular presentation. I've seen labs presented and they're expecting you to identify what's going on, or being able to make a diagnosis of HG. And if you notice that there is a decrease uh, in your chloride ion, then that could be a subtle indicator to move you in the right direction. Okay. We might see a mild increase of AST, ALT, um, but you might not see that as well. Okay. So what's the main thing here in terms of how we want to treat dietary modifications? Again, B6 and doxylamine. Your second line option is going to be your antiemetics. And then your third line is making sure that the patient is properly hydrated and that you're replenishing your electrolytes if possible, if need be, right? In the event that the vomiting continues to occur, you might have to consider TPN, right? But please make sure that as you're going through your questions and making your decision, that you have already exhausted the previous two options in terms of treatment. Okay. And I believe this is the last presentation here that we have before we go into some questions. Would be hepatitis, right? Could be viral or autoimmune. So that's presenting with fatigue, anorexia, right upper quadrant pain, nausea, jaundice. One thing of note is that you might see um, liver enzymes in the thousands, right? That should gear you towards, it's not the 2x that we associate with some of the other diagnoses, or slight elevation or mild elevations, or we're possibly up into the thousands, right? That should have you thinking hepatitis in particular. You also, if you have the labs done or if it's presented in that way, you might see positive you might see positive indicators for antibodies for your hepatic presentations, hepatitis A, B, and C, right? So just be cognizant of that, and that might be one of your decision makers, one of the decisions that you need to make whenever you're going about trying to figure out your diagnosis. Also note that vaccination is going to be recommended for hepatitis A and B, and that you're screening all pregnant women for hepatitis B and C. And when do you start your antiviral for hepatitis B? Whenever the viral load is over 200,000 in the third trimester, because we're trying to reduce transmission there. Okay. So as stated, we're going to see elevated um, elevated liver enzymes, positive viral serologies, right? And then just make sure that you've ruled out other causes of elevated liver enzymes, including ICP and AFLP. Your first line is going to be supportive if it's viral, tenofovir for your high viral load, as we mentioned there for hepatitis B. If it's autoimmune, steroids, particularly prednisone, right? And for your third line is going to be liver transplant if we've moved into a hepatic failure. Okay. I will say for hepatitis and OB/GYN, what I've typically seen is prevention protocols that are discussed, and then when are you introducing antiviral therapy? Um, Not as much the treatment after, if you're looking at the presentation of an acute hepatitis. So just want to note that. Okay, so let's look at some practice questions. I'll give you a second to pause um, and look at this question. All right, so hopefully you're able to do that. As we're looking at this question, there's a couple things that we want to look at and consider. So number one, we said 6 hours apart, we had readings of 144.92, right? 144 over 92, sorry, 6 hours apart. And then we're seeing a positive dipstick +2 protein. I want to note that in the chart that we had above, we had +1 as well in terms of the three ways that you would look at seeing proteinuria. So hopefully you're thinking that this particular patient has preeclampsia. Note that there's mild headaches, right? But there's no visual changes, abdominal pain, or swelling, right? So we don't necessarily see any severe features. So this should be a preeclampsia with severe features. So how do we manage that? So if we haven't gotten to severe features, right, we are not as worried about an acute crisis at this moment. Okay, so we can manage this outpatient, and because we can manage this outpatient, we're going to monitor and then plan for a delivery at 37 weeks. So your answer should be C. Okay. Again, preeclampsia without severe features. We are thinking that we want to monitor outpatient and then plan for delivery at 37 weeks. All right. I'll give you a second to pause and answer this question. All right. So hopefully you're able to do so. And with this one, um, we're seeing a new patient that's presenting 35 weeks with gestation, and then blood pressure is 168 over 110. That's significantly high. Platelets are less than 100,000. That's high. AST elevated, and creatinine is elevated as well. We should be leaning into consideration that this is preeclampsia with severe features, right? With severe features. So if it's preeclampsia with severe features, of our options here, In terms of delay, that's not going to make sense. Just managing the hypertension alone isn't going to make sense. Rechecking for 6 hours, seems to be a pretty urgent consideration at the time. And then if we are we going to administer a corticosteroid? Well, that would be for HELP syndrome, but we didn't necessarily say HELP as we don't have an indication of a hemolytic crisis. So because of that, our answer should be B, right? Initiating antihypertensives, that prophylaxis to try to stave off seizures, and then we need to proceed towards delivery um, at this time. Okay, let's go to the next one. Give you a second to answer this. All right. And so for this particular patient, shows up to the emergency department. So we have a generalized tonic-clonic seizure. Okay. So we have to rule out, go through our differentials for seizures, but we can narrow things down pretty quickly, not just because of this lesson, but also because the blood pressure is significantly elevated, over 170, over 112, right? So that should lead us to the understanding that this is eclampsia, right? And so for eclampsia, if you remember, one of the things that we need to do for eclampsia is to administer magnesium sulfate and prepare for delivery, right? So some of these other options are either delaying delivery or you're not administering the right medication for this particular setting of eclampsia. So magnesium sulfate and then preparing for delivery. Okay, that answer should be B. Okay, let's try the next one. Give you a second to review. All right. So in this particular case, we have the patient presenting with malaise, nausea, right upper quadrant pain. Um, in this particular case, the patient also has an elevated blood pressure, right? Decreased platelets, elevated liver enzymes, and elevated LDH, as well as schistocytes. So this should have led you in the direction of dealing not just with preeclampsia with severe features, but the specific consideration of HELP syndrome, right? And so for HELP syndromes, I'm sorry, for HELP syndrome, our thought process should be to administer magnesium sulfate. Okay. Now, you notice how this is the best answer, even though it says corticosteroids. If you remember, we had the corticosteroids consideration of prior to 34 weeks. Um, but in this event, this is our best answer. In doing so, just recognize the use of corticosteroids as an additional medication that we're considering whenever a patient's been diagnosed for HELP syndrome. But the main marker of that is going to be surrounding 34 weeks. Okay. Give you a second to answer this one. All right. So here we have uh, 34 weeks gestation, worsening pruritus, particularly on the palms and soles, right? We have increased bile acids, platelets and coagulations were normal, right? So what should we do? What are we thinking? Well, hopefully you're thinking ICP, and with by thinking ICP, one of the first things that we're going to try to administer before we offer topical corticosteroids or antihistamines, we need to increase bile flow. So that's going to happen by our answer C of beginning your ursodeoxycholic acid and planning for delivery at a later time. If the symptoms persist, and as you see probably in the real world, they're probably going to administer the antihistamines and corticosteroids topically at the same time, but you still want to make sure you're moving that bile acid with UDCA. Okay, go on to the next one. Give you a second to answer. All right. So we have a 36 week gestation, patient with nausea, vomiting, right upper quadrant pain, and confusion. Right. With this time we see elevated blood pressure. Right. And I left this in here for a reason because you might see this particular presentation. Um, and it might guide you to think that maybe I'm dealing with HELP, or I'm dealing with a feature that is a preeclampsia with severe features. But one of the things that I want you to consider specifically for this is going to be your hypoglycemia, right? Um, so hypoglycemia, in the midst of presentation that looks similar to acute fatty liver pregnancy versus HELP, I want you to lean towards acute fatty liver pregnancy, right? That hypoglycemia is of note there. Even though we have hypertension here, right? Your prolonged bleeding, right? Your coagulopathy, your elevated ammonia, and your hypoglycemia. Those are liver failure considerations that we are concerned of, and that would move us towards considering acute fatty liver of pregnancy in this particular case. So your answer should be C. All right. And that is the last question for this particular presentation. I appreciate you for watching this presentation. If you find it helpful, please share it with others. Um, Look forward to seeing you on the next one. Have a great day.